Good afternoon, everyone. I would like to welcome everyone to this webinar, which is an introduction to multidimensional grief therapy. Uh, my name is Dr. Keith Cruz, and I'm lucky enough to serve as one of the co-directors of the CTRJJ, or the Center for Trauma Recovery and Juvenile Justice. And those of you who are unfamiliar with the CTRJJ, we are a Category 2 training and technical assistance center that's affiliated with the National Child Traumatic Stress Network and funded through SAMHSA. And the mission of the CTRJJ is to support a comprehensive framework for developing, adopting, implementing, and sustaining evidence-based trauma-informed services for youth who are either at risk for or are in the juvenile justice system. So the CTRJJ really works to support this comprehensive framework for providing trauma-informed services, not only for youth but also for families as well. And other parts of our mission are also to support the staff and mental health professionals, behavioral health professionals, and juvenile justice professionals working from within the system as well. And so we are very, very happy today to be bringing to you this introductory webinar on a very innovative, evidence-based treatment protocol called multidimensional grief therapy. A few housekeeping and reminders before I introduce our speakers. The QA function is available throughout the webinar, so please submit questions to the presenters just using the QA function at the bottom of your screen. You can put questions in throughout the webinar as they emerge, and then I'll kind of facilitate some sharing of those questions with the presenters, and we will address as many questions as time permits at the end of the presentation. This webinar is being recorded, and so all registrants will receive a follow-up email notification from the CTRJJ when the webinar recording is available on the CTRJJ website and also our YouTube channel. And at the end of the webinar today, we will have some information. If you would like a certificate of attendance, there will be some instructions at the end of our time today for you to be able to download from the CTRJJ website, a certificate for attendance. Please note that this certificate is for personal use only and to log your time with us. It is not eligible for CE credits. And so now I'd like to take a moment to introduce our esteemed speakers for today's webinar. First, I'd like to introduce Dr. Julie Kaplow. Dr. Kaplow is a licensed clinical psychologist and board certified in clinical child and adolescent psychology. She received her BA in psychology from the University of Michigan and her PhD in clinical psychology from Duke University. She completed her internship at Boston's Children's Hospital and the Harvard Medical School, and also followed that with postdoctoral training in the Center for Medical and Refugee Trauma at Boston Medical Center. Dr. Kaplow holds a number of administrative and academic positions. She currently serves as the Executive Vice President of Trauma and Grief Programs and Policy at the Meadows Mental Health Policy Institute and is Executive Director of the Trauma and Grief, or TAG Center, at the Hackett Center for Mental Health in Houston, Texas. Dr. Kaplow is also the Executive Director of the TAG Center at the Manning Family Children's Hospital in New Orleans and Professor of Psychiatry at Tulane University School of Medicine. She's also the CEO of the Lucene Center for Trauma and Grief, a group practice that provides no-cost therapy to youth exposed to trauma and loss across both Texas and Louisiana. Dr. Kaplow has published widely on the topics of childhood trauma and grief and has served as principal investigator on numerous grant-funded programs focusing on enhancing resilience in youth who are exposed to various forms of adversity. She's the lead author of Multidimensional Grief Therapy, co-author of Trauma and Grief Components Therapy for Adolescents, and co-author of Trauma Systems Therapy. Dr. Kaplow has served as a consultant to the DSM-5 subwork group on prolonged grief disorder, on the ICD-11 work group on disorders associated with stress, the National Academy of Medicine Scientific Advisory Council on child death, and also on the Mass Violence and Trauma Working Group for the Federal Bureau of Investigation. Across all of these very impressive roles and responsibilities, Dr. Kaplow oversees the development, evaluation, and dissemination of trauma and bereavement-informed best practices across the nation. Following various tragedies such as Hurricane Harvey and school shootings, including the school shooting in Santa Fe, Dr. Kaplow and her team have provided evidence-based risk screening and interventions to impacted children and families. More recently, she and her team have been conducting trainings and providing ongoing consultation to the Uvalde School District following the Robb Elementary School shooting. In addition to Dr. Kaplow, I'd like to introduce our co-presenter, Marissa Navitz. Marissa is a licensed clinical social worker and supervisor with over 20 years of clinical experience, as well as expertise in education, training, and program development. Marissa completed her bachelor's degree in psychology from Texas A&M University and a master's of social work from the University of Houston. As Vice President of Education and Training at the Trauma and Grief Center, Marissa directs the training program and provides school and community-based trainings in a variety of mental health topics related to supporting youth exposed to trauma and loss. In her previous role at the TAG Center, Marissa supervised a clinical team and provided evidence-based trauma and bereavement-focused services as part of the coordinated response efforts in the community of Santa Fe following a school shooting in 2018. And prior to joining the TAG Center, Marissa spent much of her career working as a clinical social worker and supervisor at MD Anderson Cancer Center, creating programming for children whose parents had cancer. So I'd really like to welcome everyone to this webinar. And at this point, I will turn it over to Julie and Marissa. Thank you so much.
Thank you so much for those introductions, Keith, and for inviting us today. We are really happy to be here. And what I thought we could do is start by talking about childhood grief and a theory called multidimensional grief theory. We are also going to talk about why it's important to distinguish PTSD from grief, and also the core components of multidimensional grief therapy. So we're not going to do a deep dive into MGT today, but really give you sort of an overview of the different components of multidimensional grief therapy and how they work. And then we're also going to discuss learning collaborative details for an upcoming MGT Learning Collaborative, and then hopefully have plenty of time for questions and discussion at the end. A few disclosures. Obviously, we're going to be talking about MGT today. We will also be talking about another treatment called trauma and grief component therapy for adolescents, and one of our assessment tools called the PGD checklist. And before we launch in, I wanted to just tell you a little bit about what we do at the Trauma and Grief Center. So the TAG Center has 4 different pillars, and the first is that we develop evidence-based assessments and interventions for children who've experienced any form of trauma or the loss of a loved one. We also do training and professional education in trauma and bereavement-related topics and interventions, including the learning collaboratives that we'll tell you more about. We also do research on children's needs and strengths in the context of trauma and loss, and treatment effectiveness. So we are constantly measuring the impact of the treatments that we're disseminating. And then in terms of policy, we make recommendations based upon what we know are trauma and bereavement-informed best practices. So in other words, if we know that a child in the US experiences a trauma or the death of a loved one, how do we ensure that they receive best practice care wherever they're most likely to be identified or served? And that is often in school settings and pediatric settings, and that's really where a lot of our work takes place. I also want to mention our Lucene Center. So as Keith mentioned, Our Lucene Center provides no-cost teletherapy to children who've experienced trauma or loss across the states of Texas and Louisiana. And the Lucene Center really works hand in hand with our TAG Center. In other words, the clinicians at the Lucene Center have joint appointments at the TAG Center. And what this does is that it provides a very unique synergy between the science and the practice. So the research helps to inform the work that we do at Lucene, and the clinical work that we do at Lucene helps to prompt other research questions or things that we know are important to investigate about trauma and grief. And so I want to start by talking a little bit about bereavement. And I know that I'm probably preaching to the choir here, but just so we're all on the same page, when we're talking about bereavement, what we're really talking about is the experience of deprivation or loss by death, whereas grief is the psychological or behavioral response that arises from bereavement. In other words, bereavement is to trauma as grief is to PTSD. And this is an important distinction because, as you'll hear as we continue to talk, there have been a number of studies looking at the impact of bereavement on future outcomes in children. There have been far fewer studies that have looked at grief, and that's really one of the areas that we're very focused on investigating ourselves. And so why are we focused on bereavement in particular? Bereavement is actually the most frequently reported type of trauma in clinic-referred youth across the United States. It's also the most common form of trauma worldwide, and this is even more so the case due to the pandemic. It is the most distressing form of trauma among adults and youth in the general population. So if you were to ask anybody, what is the hardest thing that's ever happened to you, the vast majority would say it was the death of my mother, my brother, my father. It's also the strongest predictor of poor school outcomes above and beyond any other form of trauma. So when we looked at about 10,000 students across the country, we found that the sudden death of a loved one was actually the strongest predictor of poor school grades, school dropout, lack of connectedness to school, problems learning, and that was above and beyond sexual abuse, physical abuse, or even witnessing domestic violence. So that's another reason why we are very focused on getting into the schools and helping them recognize the importance of identifying kids who are bereaved early on. I also want to mention what is probably the most important part of why we are looking at MGT in the context of justice-involved youth. So bereavement is very common among justice-involved youth, and in fact, most detained youth report the death of a close loved one, with over 70% experiencing at least 2 or more significant losses. Detained youth report experiencing their first death on average by age 5. So this is happening very early on in life. And these deaths are most frequently characterized by violent losses. So these are predominantly homicide. And that is also why we feel it's so important to be paying attention to the bereavement and grief among these youth and not just trauma. And so the take-home message here is that children's grief reactions, not just bereavement, play an important role in future psychological functioning. So again, it's not just about the death itself, but it's about how those children or adolescents are reacting to the death. And there are some important facts that I want to go over about grief. And again, most of you know this, but we know that most bereaved children will go on to lead healthy, happy, productive lives. So we in no way want to pathologize bereavement. There is no right or wrong way to grieve, and there is no set timeline for grief. For some reason, our society has this notion that people should be over the death within a year. Now, we know that that's not the case, and we know that, in fact, people don't get over a loss like that. And grief is not a problem to be fixed. It is actually a natural part of life and a reflection of the relationship we had with the person who died. So the goal is not to rid children of their grief. The goal is to provide them with more tools in their toolbox to deal with the grief as it comes and goes. And so I thought that this really depicted this concept nicely. So people tend to believe that grief shrinks over time, when in reality, we grow around our grief. And what we're doing as therapists or facilitators is helping kids to grow that toolbox so that they're able to cope with the grief over time. So again, it's not shrinking the grief, it's helping them to address the grief as it comes and goes. So often we get this question, how do children typically grieve? And this is very difficult to answer. And the reason that's difficult to answer is because there have been very few large-scale studies of bereaved children, even fewer that have followed them over time, and even fewer with diverse populations. We also know that grief reactions are influenced by a host of factors, including the child's developmental level, their previous life experiences, their relationship to the person who died, their culture, their religion, their spiritual beliefs, their family, their social environment, and even the cause of death. So to be able to say that this is a typical way of grieving versus atypical is very challenging because we have to always consider these other factors in the context of the death. However, we do know something about what typical grief reactions look like. We know that they can still be very intense, so we often see that pining and yearning for the person who died, sadness or anger or protest over the loss. And this is often at least temporarily associated with decreased functioning. So within the first 6 months to 1 year of a death, we often see that kids struggle a little bit more, at least, with school, peer relationships, maybe even relationships at home. But what tends to happen is that there typically is a transition from more pain to more pleasant reminiscing over time. And in fact, one of our studies found that if parents, surviving parents, attempt to engage their bereaved children within the first 3 months of the death by having them reminisce about positive memories of the person who died, within those first 3 months, that can actually backfire. What we find is that children's symptoms actually become elevated. However, after those 3 months have passed, when the parent engages the child around positive reminiscing activities, it can actually be incredibly helpful. So it seems to be that there's this 3-month mark where in that initial phase, what children really need is the validation that this is very hard, that we are all sad, instead of remember that great time we had when we all went fishing with dad. However, after those 3 months, when we start to engage kids around those positive memories, that's when they actually start to do a lot better. And so we want to just keep that timing piece in mind. I also want to just mention prolonged grief disorder because, as you all know, this is a newer diagnosis in the DSM-5-TR. And to diagnose a child with PGD, the death had to have occurred at least 6 months ago, which is different than adults. For adults, it had to have occurred 12 months ago. The symptoms have to be present for at least a month and be intense enough to cause impairment. We know that approximately 10 to 20% of bereaved youth in the United States will develop PGD, but those rates tend to be closer to 20% or even a little bit above, even closer to 25% among youth who are exposed to homicide. So we know that this is not a one-size-fits-all situation and that PGD can vary depending on the circumstances of the death. I also just want to mention invisible losses. And what we mean by that is really this term disenfranchised grief. This is a loss that is not openly acknowledged, socially mourned, or publicly supported. And disenfranchised grief is incredibly common among youth in juvenile justice settings. And the more minority identities that a person carries, the more likely it is that their death or their surviving loved one's grief will be minimized or ignored altogether. And I want to just share a quote with you. This was a child that we treated actually in New Orleans. This is a 16-year-old Black male. My teacher couldn't understand when I started crying in class after my cousin was killed. She was like, "Isn't this normal for you by now?" This dismissive attitude of, this is just the norm, and not grieving and not allowing that child to grieve in a way that we would want him to be able to grieve is incredibly common. And it's also common, especially among youth in the juvenile justice settings. Homicide victims, especially Black and brown individuals, are often blamed by society for their own death. And for this reason, addressing disenfranchised grief necessarily involves acknowledging losses, identifying and expressing the full range of emotions that adolescent or young adult might have, including anger and rage about the circumstances of the death, and highlighting positive traits or behaviors of the person who died, because that is not something that society is providing for that youth. And so again, these are all things that we're taking into account as we begin to address grief reactions among juvenile justice youth. And now I want to turn to our theory of grief, and I've had the privilege of working closely on this with Chris Lane and Bob Pynus for the last 15 years or so. And what we find is that grief is not dichotomous. And so, even when we're thinking about the diagnosis of PGD, it's not children have or don't have maladaptive grief. What we find is that kids are high or low on these three different dimensions of grief. And the first is separation distress. This is yearning or longing for the person who died. The second is existential or identity distress. This is feeling lost without the person, or how am I going to get through life without the person here? And the third is circumstance-related distress. And this is exactly what it sounds like. It is being very preoccupied with the way the person died. So things like, I wish I could have intervened, or I wish they didn't have to suffer so much. But what we also know is that there is an adaptive counterpart to each of these dimensions. So in other words, with separation distress, the best example I can give you is I was working with a young girl whose mother died of cancer. Her mother was her best friend, and so she missed her terribly. And what we found is that the more she engaged in behaviors that she used to do with mom, the more she felt connected to her mother in a very different way, but in a healthy way. So for example, she started making her mom's favorite apple pie. She started taking swim lessons because swimming was something they loved to do together. And because of that, she started to feel more connected to mom, again, in a healthy way. That would be the adaptive side of separation distress. With existential or identity distress, we hear from adolescents all the time, things like, I don't know how I'm going to get through life without my dad here. But we also hear them saying things simultaneously like, I want to live the kind of life my dad would have wanted me to live, or I want to do things that would have made my dad proud of me. That is the adaptive side of that dimension. And with circumstance-related distress, believe it or not, we see this all the time, even in young kids, where they want to transform the circumstances of the death into something that can help other people not have to suffer in the same way that they did. So for example, I was treating a young boy whose father died in a tragic plane crash. And when I asked him, what do you want to be when you grow up? He said, I want to be an engineer so I can make planes that don't break anymore. And we hear this all the time from kids. I want to raise money for breast cancer because my mom died of breast cancer, or I want to become an ER doctor because I want to save lives the way I wish they had saved my brother. And so when we're talking about MGT in particular, what we're really doing is not just trying to alleviate those more unhelpful or maladaptive grief reactions, but really harness and grow the naturally occurring adaptive grief reactions that we see in the kids that we treat. And so I want to give you just a few examples of what this looks like. These are taken directly from actually both trauma and grief component therapy and MGT. So this is separation distress. And this is a boy whose father died. Mom is saying, your dad would want you to enjoy these tickets. Why don't we go to the game together? And he's thinking, I can't ever go back there anymore. It won't ever be the same without him. And we hear this all the time from kids who have lost a loved one, where they don't want to engage in the things that used to bring them pleasure because doing those things without the person there is just too painful for them. This is an example of existential or identity distress. This is a girl whose father also died. He was her biggest cheerleader, and she just got accepted to the college of her choice. She's throwing it in the garbage, and she's thinking, I don't care about my future anymore if he's not going to be a part of it. He'll never see me graduate anyway, so what's the point? And again, we hear this all the time from kids where they will give up on their hopes or dreams or aspirations for the future when the person who was their biggest supporter is no longer there physically. And then finally, this is a classic example of circumstance-related distress. This is a girl whose brother died in a gang fight. She's thinking, every time I see his picture, I can't help thinking about the night he got killed. It gets me so mad that it's hard to remember the good times. So she may want to positively reminisce about her brother, but every time she thinks about him, she is flooded with those very upsetting and anger-inducing thoughts and feelings about how he died, and she just can't hold on to those positive memories. And so why is this framework important? We believe it's important for a few reasons. Different dimensions of grief may actually be more prominent at certain developmental stages. And this is what we're starting to see in our research, is that separation distress tends to be more common in children under the age of 12, where existential or identity distress tends to be more common in adolescents. And that makes sense if you think about the developmental tasks associated with each of those age groups. Different dimensions of grief may not be present in all bereaved populations. And so, similar to what I mentioned earlier, what we find is that circumstance-related distress tends to be more common in populations where there are high rates of homicide, whereas we don't see as much circumstance-related distress among youth who lose loved ones for other reasons. And then finally, this is probably the most important takeaway, different dimensions of grief may require different treatment components. And this is what is really what we're finding in our research. Different therapeutic activities are used to address those different grief domains. So in other words, the way that we help kids to support them through their separation distress is very different than how we support kids through their circumstance-related distress, for example. And that's exactly what we're doing within MGT, is we're really honing in on those different dimensions in order to ensure that what we're doing is working. What we find is that those one-size-fits-all grief treatments are not as effective because we're not honing in on which dimension that child is really struggling with. And so I do want to turn to a very important link between bereavement and suicide risk, because this is also something that we're directly addressing through the use of MGT. So suicide is, of course, a major public health concern. It's the third leading cause of death among adolescents, second leading cause of death among children. 20% of high school students report seriously considering suicide, and 9% report an actual attempt in the last year. And we know that these rates have actually gone up since this study was conducted. We also know that adverse life events are linked to suicide risk, including all of those that you see here. And of course, bereavement is a very significant predictor of suicide risk. So interpersonal losses tend to be one of the most potent predictors, actually, of suicide. And why is this the case? Well, one of the things that we've recognized in bereaved youth is that they do tend to have what we call reunification fantasies. This is also taken from trauma and grief component therapy, but this is a girl whose best friend died, and she's thinking, it doesn't matter if I live or die. If I crash, the bad news is I'm dead, but the good news is I get to see my friend again. And we hear this kind of thing all the time from kids who are bereaved, that they may not have true suicidal ideation, but they can't figure out another way to feel connected to their person who they lost. And obviously this depends heavily on the person's spiritual beliefs and, how they're making sense of if there is an afterlife. All of that is taken into account, but we see this time and time again among bereaved youth. And so what we want to do here is not necessarily panic and believe that they are actually going to attempt suicide. But what it does tell us is that there is a need for a more thorough evaluation to determine, do they actually have a plan? And really, is this how they're thinking about their situation, that the only way that they can be happy again is to be reconnected in an afterlife somehow? We also know that the interpersonal psychological theory of suicide can tell us a lot about why there is this link between bereavement and suicide risk. So we know that Joiner's theory states that two things have to be present in order for someone to truly be at risk for suicide. The first is thwarted belongingness, and this is just a fancy way of saying being very lonely. So a sense of loneliness, perceived lack of support. And the second is perceived burdensomeness. This is when one has become a drain on the resources of others. In other words, people would be better off without me here. And the reason this is relevant is because we hear this and see this all the time in bereaved youth. In one of our studies, we have these direct quotes from kids who have lost a loved one. The first one says, "Nobody understands me. No one knows what this is like. People think I'm weird because I don't have a mom anymore. Anyone I get close to dies, so I shouldn't get close to anyone anymore." All of these very common thoughts and feelings are actually part of that cluster of thwarted belongingness, where they truly feel that sense of profound loneliness. We also hear about perceived burdensomeness. Mom starts to cry every time I mention how much I miss dad. Therefore, she'd be better off without me. If I had been better behaved in school, mom wouldn't have been so stressed and had a heart attack. And, we hear these things all the time from kids where they will actually create narratives about how they were responsible. And that, of course, leads to that intense sense of perceived burdensomeness. So I'm raising this because these are things that we see and hear from bereaved youth very frequently. And this is why we also need to be attuned to the fact that they may actually be at risk for suicide. Okay, and I am going to turn it over to Marissa, correct?
Julie, yes.
Okay.
Okay, so now I want to just briefly touch on why we think it's important to distinguish PTSD from grief. So PTSD and grief are not the same thing. They have different precipitating factors. So trauma reminders, which we'll talk about in just a minute, can lead to trauma reactions, whereas loss reminders can often lead to grief reactions. They have different physiological effects. So post-traumatic stress feels very different in the body from grief. We know post-traumatic stress can feel like hypervigilance, depressive symptoms, memory loss, things like that. Whereas grief can often feel like immense sadness for kids and kind of like a heaviness. PTSD and grief require different assessment tools, and we use those assessment tools to help us determine what a child is experiencing at the time that they present for services, so that we're not just eyeballing and making a guess as to what kind of intervention we think will be the best fit for kids. And then most importantly, they require different practice elements. So the way that we go about treating post-traumatic stress looks very different from the way that we go about treating grief reactions. So I want to touch on this concept of trauma and loss reminders, which I know many of you are already familiar with, but the reason that this is important is because the way we go about supporting kids with their trauma reminders looks very different from the way we go about supporting kids with loss reminders, and those are both covered in multidimensional grief therapy. So trauma reminders are things that we experience through our five senses that remind the child of the traumatic event. They take their brain, they flip that switch in the child's brain that tells the child they're in danger, they need to fight, flight, or freeze, and it causes distress and all of the stressful hormones and chemicals running through their body. Trauma reminders can often lead to PTSD or to circumstance-related distress, which again is that the preoccupation, the distress over the way their person died. Loss reminders are things that we experience through our five senses that remind us that the person is gone. So not the way the person died, that would be a trauma reminder, but just of the absence of the person. And loss reminders can often lead to grief reactions. One of the other key differences between trauma and loss reminders is that trauma reminders are always distressing. Loss reminders can also be distressing. They can also be comforting. So I worked with a 12-year-old whose father died. And for the 12-year-old I was working with, her father's recliner in the house, in the living room, was a really comforting loss reminder for him. So she saw it and it would remind her that he was gone, but she would sit in it and it would help her feel connected to her dad, help with that separation distress. Her sibling, on the other hand, would see the recliner and would become distressed. For her, it had a different kind of response in her physiologically. So trauma and loss reminders are very subjective. I'm going to share this example of a semi-structured clinical interview that we did at the TAG Center. I do want to give a content warning. This is about a 17-year-old who witnessed the murder of her mother by her father. So please just be mindful as we share some of the details of this interview. So the clinician says, do you get very afraid, upset, or sad when something reminds you of what happened? The patient says, oh yeah, screaming, the door slamming, firecrackers, that, and seeing or hearing arguments. Whenever I hear somebody fussing or anyone arguing, especially if it's a man, I want to run and just go get a knife. It brings me right back. I get to the point where I'm so scared, I'll kill you if you make another move. I wouldn't mean to do it. It's just out of fear. They could even just be playing, but just hearing that scream, it makes me feel like I'm right back there again. The clinician says, and when these things happen, how much do they bother you? The patient says, on a scale of 1 to 10, I'd have to say 20. So you can see here that the patient, what she's describing are trauma reminders. These are things that remind her of the event of the time when her mom was killed. Things like doors slamming, people screaming, the sound of firecrackers, hearing a man's voice. These are things that are kind of flipping that switch in her brain that's telling her again, she's in danger, even though now she's not necessarily in danger. So those would be trauma reminders. Then the interview continues and the clinician says, have you tried to stay away from people, places, or things that remind you of what happened? The patient says, I can't go to the mall anymore. I went only one time after she died, but I couldn't go after that. There's a lot of stores and stuff that I like there and I want to go so bad, but I can't because I don't have my mama anymore. The clinician says, is that because the mall reminds you of what happened? Or the patient says, the mall just reminds me of her in general. Through good times and bad times, we always went there together. So here she's describing the mall as a loss reminder. So this is, and it's an upsetting loss reminder for her. So she's avoiding the mall because it's reminding her of the absence of her mother. And so this is just a really important concept and something that MGT, that we work on in MGT with the kids and helping them identify both trauma and loss reminders, and then helping them examine ways that they can cope with the reminders as they're faced with them. It's kind of a running theme throughout MGT, throughout the whole intervention. Okay, Julie, I'm going to turn it back over to you.
Okay. So now what we're going to do is talk about MGT itself. And I want to just start by telling you that, the field of grief is still, believe it or not, really in its infancy in terms of the number of studies that have been rigorously conducted looking at the effectiveness of treating grief in kids. And so when we did our review of those studies, what we found is that really there are only about 6 that have been rigorously tested. Some of them are group-based, and those include the Family Bereavement Program, Erwin Sandler's work, Grief and Trauma Intervention by Allison Saloom, and then TGCT by Bill Saltzman et al. And then we have the individual treatments. And, some of these can also be used individually, but Grief Help, TFCBT for childhood traumatic grief, and then MGT. Both TGCT and MGT can be used both individually as well as in groups, but this was really kind of our summary of what was out there at the time. And but what we did find is that there are some key components to all of these interventions that we think are important for treating grief in general. And those are, Marissa's going to go over those in more detail in just a few minutes. But just to give you a sense of what multidimensional grief therapy is, this is an assessment-driven intervention based on multidimensional grief theory. And I did see a question already about how do you go about assessing grief and distinguishing that from PTSD. One of the measures that we use pretty frequently is called the PGD checklist. What this will do is that this will actually give you, the DSM diagnosis of PGD if necessary, but it can also be scored according to multidimensional grief theory. So it will literally tell you this child is high or low in separation distress, existential, or circumstance-related distress. So that is often what we use to determine which elements of the MGT therapy to utilize. It promotes adaptive grief reactions and reduces unhelpful grief reactions. To our knowledge, it is the first evidence-based, grief-focused intervention for children and adolescents that directly addresses those 3 primary domains of grief. And this is really designed for kids ages 7 through 18, although we've used it all the way up to age 22. It addresses the interplay between trauma and grief, so a lot of the exercises deal with traumatic losses. It provides a continuum of grief-informed care, given its tiered approach, and I'm going to talk more about that in just a minute. And again, it can be used individually or in groups. So we have a phased approach to MGT, and what this means is that the first phase is really a tier 1 intervention. It basically deals with the different dimensions of grief, understanding how grief changes over time, helping kids to identify loss and potential trauma reminders. It enhances emotion regulation and cognitive coping skills. And the beauty of this phase is that it can really be administered by non-mental health professionals who are trained. So in other words, this can be used, and we have used it in faith-based organizations, bereavement support centers, schools where it's actually school nurses who are administering this. So you don't necessarily have to have a mental health background to administer phase 1. And the reason we did this intentionally is because we know that grieving kids are everywhere. And in order to really provide that continuum of care for bereaved youth, we need other caring adults in the community to be equipped to support them. The second phase is really, again, it's really getting into the story of the loss, and this is where we do a lot of grief processing. So we do a creation of a loss narrative. We're going to talk more about that, where we focus on each dimension of grief. We enhance ongoing connection to the deceased, legacy building, and meaning making. We also promote caregiver grief facilitation, which we'll also talk about. And this is the phase that is typically administered by a mental health professional. So because we are doing a deep dive and doing a lot more cognitive restructuring in this phase, this is when we do need the person to have a mental health background in order to really be able to utilize that phase. And I also just want to touch on some of our findings. So we are continuing to evaluate the effectiveness of MGT, but we do see significant reductions in symptoms of distress after receiving just phase 1. So even after phase 1 alone, we saw a 40 to 47% decrease in grief, maladaptive grief, post-traumatic stress, and depressive symptoms. And then among those youth who received phase 2, we saw an additional 22 to 44% decrease in those symptoms from time 2. These treatment effects were consistent across race, age, gender, and time since death. So it appears to be effective for a wide range of youth. And I also wanted to just touch on this study that was conducted by others actually at CTRJJ. And this was, really looking at the grief module of TGCTA. So one of the things I want to mention is that MGT is really rooted in a lot of the grief module activities within TGCTA. And what we found is that for those kids where the predominant issue is grief, we really wanted a specific treatment that would hone in specifically on those grief dimensions in a more in-depth way than TGCT does. Now, TGCT does an amazing job of this, but really for those kids where the primary presenting issue is grief and there may not be a huge need to focus on trauma per se, that is when we would use MGT. So that being said, we used just the grief module in this study. So this was 63 incarcerated adolescent males. We utilized the grief module alone, which resulted in decreased maladaptive grief, but also a 50% reduction in the number of behavioral incident reports in that setting. And I wanted to just share a little bit of the feedback that we received from the youth there after participating in the group. A couple that I wanted to just point out, I'm not going to let this happen to my own kids. I can stop the cycle. What is really amazing about the grief, dealing with the grief among these youth is that they may not have had the sort of wherewithal or insight to understand that what was driving some of the behavior that got them into trouble was actually their grief, was their need to emulate behaviors that they saw in those that they loved, who they've lost. So, for example, if they were in a gang and their best friend died, they are repeating those behaviors oftentimes as a means of feeling connected to them again. So that's often part of the reason they're doing that. Or they may feel like, my life doesn't matter anymore, so it doesn't matter what I do if I don't have this person in my life. There are lots of reasons why kids engage in these behaviors as a result of their grief reactions. And so helping to point that out is really what helps to drive their their ability to really take a look at why they're doing what they're doing and putting a stop to that. I'm finding other ways to honor my brother, ways that won't get me in trouble. This is the exact example that I'm talking about, where they're able to recognize, oh, that was me trying to honor my person. I have other ways of honoring them that are not going to, that are not going to ruin my life, that are actually going to help me. So those are the kinds of activities that we're doing within that grief module. So I just wanted to point that out. We are using MGT in juvenile justice settings in different parts of the country now, particularly Louisiana, and seeing very similar results where the grief is decreasing, of course, but the incidents of violent behavior are also decreasing significantly. And now I'm going to turn it back to Marissa.
So these are the primary components of MGT. And as Julie mentioned, some of the other interventions that are designed to address grief in youth also contain some of these components. But primarily focusing on grief psychoeducation, that's number one, with the kids and the caregivers. Emotion identification and regulation, and I'm going to share just some examples of some of the activities that we use to accomplish some of these things. Cognitive coping and restructuring, grief and or trauma processing, depending on what the child needs. There's also a session that focuses on memorializing and continuing bonds, making meaning, legacy building, and then also a session specifically focused on parental or caregiver grief facilitation and positive parenting. So here is an example. This is from the first session of some of the activities and the grief characters that we use, that we introduce with the kids. In this activity, we present the kids with a list of potential grief reactions. They're kind of listed in some thought bubbles that we cut out for the kids. And we talk about these characters. Each of these characters correlates with a different dimension or domain in multidimensional grief theory. So lost and lonely, Leo, and meaning making, Marcus, kind of go with the existential or identity distress. Majorly missing them, Mindy, and creating connections, Claire, go with separation distress. And what we do is we have the kids just sort the different grief reactions that resonate with them and match them to the different characters they think they go with. So for example, for lost and lonely Leo, a grief reaction might be, I feel like when my person died, I lost a big part of myself. For meaning making Marcus, the child might select, when I grow up, I want to help people get through tough times like the one I've been going through. Majorly missing Mindy might be, I don't like being around the things that remind me that my person is gone. And then creating connections, Claire, we might have them put, talking to my person out loud or in my mind makes me feel better. So this psychoeducation kind of helps validate and normalize that the reactions the kids are experiencing are feelings that many kids experience when they lose someone important in their lives. This is an example of the feelings faces, where we are, you've seen probably lots of different iterations of this. I know sometimes with younger kids, we use emojis or teddy bear faces. But this is a tool that can be used to help kids just even have some language for what different feelings are. So I know you all can relate to having a child and you say, let's check in and see how you're feeling today. And they just say, I don't know. And so a lot of times just having this tool is super helpful in giving them some language. Also using this tool as a way to talk about how we can experience different feelings at the same time. So you might be happy because it's your birthday, but you might be sad because your mom's not here anymore, and how those feelings can kind of coexist. This tool can be used in so many different ways. I also like to have the kids point out which of these feelings are kind of the harder or more uncomfortable feelings to have, and which feelings might be more comfortable. And then it also lets us have discussions around talking about experiencing emotions and feelings in a different range of intensity. So this is just a really helpful tool. This is another activity that we do called our feeling selfie or feeling snapshot. And this can be used in a couple different ways, but one of the ways that we use it is as a check-in. So we give the kids the feeling faces, and after we've talked about that, we ask the kids to identify, tell me, I want you to think about 3 or 4 different feelings that you're feeling right now. And I want you to assign each of those feelings a color and then use that circle to illustrate how much of the feeling you're feeling right now. And this particular example looks kind of sort of like a pie chart, but kids get so creative when they're doing this. We've seen all sorts of drawings and illustrations and words and lots of different ways that kids illustrate how they're feeling right now. I actually used this with one child I worked with MGT. We did this at the beginning of treatment. And then at the end of treatment, I had her do it again without looking at the first one. And then after she finished at the end of treatment, I pulled out the first one she had done. And it was really powerful for her to see how far she had come in treatment. So at the beginning of our time together, she had just like a sliver of happy and a lot of sadness. And then at the end of treatment, she still had some sadness, but it was much smaller and her happiness was much bigger. And so this is a really helpful tool as well. This is one of the lessons that we use to talk about cognitive coping and restructuring. And I know this looks familiar to all of you, but we kind of call this the CBT triangle on steroids, because this is our sizing up a situation. So this is kind of taking things a step beyond just talking about thoughts, feelings, and behaviors, and helping kids think about, before we even identify what the thought is, thinking about what's going on around them. What's the situation that led to the thought that they were having, that then led to their feeling, which led to their behavior? And then what was the consequence or the outcome of that behavior? We use the sizing up a situation, kind of taking it a step further with these helping a friend activities. So MGT has a lot of these sketches where we are essentially, quote unquote, helping a friend and asking kids to kind of think about things in more of a third person to give them that distance. And to use these sketches to say, okay, let's look here at what is the situation that's happening. So she's sitting at the table with her family, her mom's boyfriend is there, and she's, not having it. And so then thinking about, what thought is she having? Well, she's thinking, who does he think he is? He'll never be my dad. And then going through, what feelings might that lead to her having? What might those feelings, what behaviors, what might she do after feeling that way? And then what might the outcome of her behavior be? And then taking it a step further and saying, what might be a more helpful thought that she can have that then might lead to a different feeling, a different behavior, and a different outcome. This is another example of a sketch that's used to illustrate that existential or identity distress. And Julie mentioned, the activities are very specifically designed for each of those 3 domains. And so when we're doing our assessments with the kids, we're really picking activities that are targeting which of those domains they're struggling with. And so here's an example of a student, a child who's in a class, and the assignment is to create a card for Mother's Day. So that's the situation. And then we would ask the child, what is she thinking? And then what feelings might that lead to? What might she do? What behaviors might she have? And then what might the outcome be? And then thinking through and reworking it with a more helpful thought, replacing the hurtful thought with a more helpful thought. I'm going to now turn it back over to Julie.
Okay. So I know that so many of you, I'm sure, are very familiar with what we mean by a trauma narrative, because that's a sort of core component of so many of the trauma treatments that we use. And so when we talk about trauma processing, we're talking about the death event itself. So in the context of bereavement, usually trauma processing involves the who, what, when, and where of the death situation. And it's really designed to alleviate post-traumatic stress or some forms of circumstance-related distress associated with the death. Now, that's in contrast to grief processing. So I want to say very clearly that trauma processing can be incredibly useful and important for kids who have PTSD surrounding the death. However, it doesn't always capture the other range of grief reactions that we often see in kids after experiencing a loss. And so we use what's called grief processing within MGT. So we are really tapping into all the different dimensions of grief. We do what we call a grief story, where we ask about who the person was, what they miss about the person, how they stay connected to the person, what are ways that they can feel connected. The chapter 4, How My Person Died, is circumstance-related distress. And this is literally the only chapter that focuses on the death circumstances. So this is really the trauma processing component of MGT, is within this larger grief processing module. Chapter 5, Where Are They Now? This is where we start to talk about, any spiritual beliefs they have that they feel are helpful to them. Obviously, we're not planting seeds. This is really what they're able to come up with. But it comes up so often that we felt that we really needed a chapter dedicated to that. How things have changed, existential distress, making meaning of the death, and my life now and my life in the future. And so by doing all of these chapters, what we're really doing is we are kind of allowing the child space to talk about those wide-ranging grief reactions that they typically have. And I want to just touch on the memorializing and continuing bonds. So this is a very important part of almost all grief treatments, where we're really helping kids to hone in on ways that they can continue to feel connected. And I use this example because I think it's probably one of the most powerful that we've seen among the clients that we've served. This was drawn by a little girl whose father died suddenly. And she's drawing dad in heaven, and he's sitting at a card table playing cards with his own father, who is deceased. He's also sitting there in his reclining chair, holding a remote control from heaven. And the TV, she told us, there's only one channel for the TV, and the TV channel is the family channel, but it's actually her own family in real time. So he's able to watch her family from above. And there's a tiny little sign that you can't really read to the left that says "to real life." And so when he's watching the family in real time and feels that he is needed for some reason, whether it's a graduation or a birthday or something important, he can float on down in spirit form and be with them. And I thought this was the most poignant and maybe tech-savvy way of describing how she still remains connected to her father. And so again, this wasn't something that we told her to do. This was really harnessing her own beliefs that she had that helped her to feel more connected. And so that's really what we're tapping into when we're thinking about those continuing bonds. I also want to talk about an exercise that we've done, again, both in TGCT and MGT, that is very powerful. And it's really designed for youth who may have some ambivalent feelings about the person who died. So sadly, for many of our youth, especially those in juvenile justice settings, they may not have had the best relationship with the person who died. And so we want to be able to acknowledge that and let some of that go. And so the way that we do this is we have them write down, usually this is done in a group setting, we have them write down on 2 popsicle sticks, 2 positive traits or behaviors of the person who died that they admire or really respect. And then we have them write down on 2 stones, 2 negative traits or behaviors that may have been hard for that youth. And that can be something as benign as, they didn't like the same TV shows that I liked, or something as incredibly hurtful as they hit me or hurt me. And so what we do is we go around in a circle and we have the kids talk about their stones first, and we have them place them in a plastic bowl in the middle of the table. We then have all the kids talk about their popsicle sticks or their positive traits or behaviors of the person, place those on top of the rocks, and then we pour water into the bowl. And this is where you can just go to town with the metaphors, right? So we talk about how the waves of grief will come and go, but those sticks, those positive traits or behaviors are the things that will keep us afloat. They're not sinking to the bottom. If we were to hold on tightly to those negative traits or behaviors, we would be at the bottom. And so we don't want that. We want to sort of hold on to those sticks. What ends up happening serendipitously usually is that all of the sticks tend to cluster together, forming a raft. So we talk about being able to harness all the positive traits and behaviors of all of our deceased loved ones to keep us floating as those waves of grief come and go. And again, those negative traits or behaviors are still visible. It's not like we're erasing them. They're visible, but they're underneath the surface. And what we're paying close attention to and holding on to are those more positive traits or behaviors. So that's just one way that we're able to help kids make meaning of the loss and also address some of that existential or identity distress that we often see. And now I want to just move to one of the other common practice elements, which is really focusing on caregiver grief facilitation. And this isn't always easily done in JJ settings, but it is a very important part of the intervention that we've used repeatedly with kids in other settings. What we know about positive parenting is that routines and positive reinforcement and active listening are all associated with decreased distress in bereaved youth. And this is something that Erwin Sandler's group has worked on and found repeatedly. And what we've also found in some of our work is that it's not so much about what the caregiver is saying, but what they're doing. And what we mean by that is there are specific caregiver behaviors that tend to be associated with decreased maladaptive grief and depression in children. And these things include basic things like physical affection, hugging, smiling, consistent eye contact, being fully present, really sending the message, I want to hear what you have to say, and I'm ready to hear what you have to say. Now, that's not to minimize how difficult that can be for grieving parents. This is an incredibly difficult task to bear witness to your child's pain when you yourself are grieving. However, it's often reassuring to parents that they don't have to say the perfect thing all the time. That's what often we get questions or concerns from caregivers. You know, am I saying the right thing? Am I talking about it in the right way? And really, it's not so much about that. It's about being fully present and sending the message to the child or adolescent that you are there whenever they are ready to talk and when they want to talk to you. And one of the things that we discovered when we were really trying to investigate this concept is that there really were no measures out there at the time that tapped into the kinds of behaviors that parents may or may not be engaging in that can help or hinder children's adaptive grief. And so we developed this grief facilitation inventory that's actually embedded in MGT. So it's actually part of the intervention. And the items include things like frequency of memorializing, frequency of communication about the death, frequency of communication about the deceased person, sharing of spiritual beliefs, their response to the child's own emotions, and the parent's expression of his or her own emotions. And what we find is that this results in 4 different domains of caregiver grief facilitation. The first is ongoing connection. And so one example is my caregiver tells me about good things that I have in common with my dad. So that would be one example. Existential or existential continuity and support. An example of this is my caregiver lets me know that I can still have a good life even though my person has died. The third is caregiver grief expression. An example here is my caregiver tells me how he or she is feeling about my person's death. And then finally, grief inhibition and avoidance. So this is my caregiver tells me not to talk about how my person died with people outside of my family. Now, I'm sure you can imagine that there is one category here where that contributes to the child's distress, and that is actually the grief inhibition and avoidance. All of the other domains actually help kids to grieve in healthy and adaptive ways. The grief inhibition and avoidance, again, sends the message that it's not okay to talk about this. And it also sends the message that this is something taboo or shameful or embarrassing, and we're not going to go there. And what that does is it increases the child's own avoidant coping, which again leads to worse outcomes. So one of the things that we do within MGT is we go through the grief facilitation inventory, and then we ask the child to identify the top 3 things that their caregiver is doing that is actually helping them at home to grieve. And then the top 3 things that they wish the caregiver might change. And what that does is that it sheds light on things that the caregiver may have had no idea about. One example is that we were working with a family where dad had died, and mom decided that it was just too painful to see photos of dad on the fireplace mantle. And so she took all of the photos down. And that was helping her to grieve. But one of the first things that the child said in treatment was, I really wish I could still see photos of my dad. It's almost like I forgot what he looks like, and I want to be able to see him. And so hearing that and understanding that, helped mom to put those photos back up in places where her child could see them and where she could choose to see them. So again, parents often have the best of intentions, but often assume that the way they're grieving is the same way the child's grieving, and that is usually not the case. Okay, so I am going to turn it back to Marissa, and that's just to say that we hope we've given you just a taste of MGT, but of course would love for you to participate in the Learning Collaborative if you're interested in doing a deeper dive and learning more about those practice elements.
And we're going to have time for questions at the end, but I did want to address, because I've seen this a few times in terms of MGT with ambiguous loss. So losses that are not related to death, but more like deportation of a parent, incarceration of a parent, kids who are in the foster care system, all those types of other types of losses. And while MGT was designed originally for loss by death, we have certainly used MGT with kids who are experiencing more ambiguous loss. It does require some modifying of some of the activities, but that's something we also touch on in the MGT Learning Collaborative and how to use and modify some of those activities. So what's happening? This is kind of a snippet. This webinar today is a snippet to just explain what MGT is, but we are offering a 2-day training in MGT. And I'll share the dates on that in a minute, but we're going to be launching applications on May 21st. You'll have 2 weeks to apply if you're interested. We do have to do an application process because we have had just an overwhelming amount of interest in this training when we offer it. Those of you who are attending today will be sent the link to the application via email on May 21st. You will be notified of acceptance to the training by June 13th. The training dates are July 16th and 17th. That's a virtual training. We will also offer 6 months worth of consultation calls. So following the 2-day training as part of this learning collaborative process, you will be offered 1 hour per month of a call to help support your implementation of MGT and talk through any barriers or challenges that you're having. The time for the training is 9:30 to 3:30 Central Time, 7:30 to 1:30 Pacific Time, 8:30 to 2:30 Mountain Time, 10:30 to 4:30 Eastern Time. So those are the details of the training. That is where I saw some questions about how to access some of the handouts and things. That's how you do it. You have to attend the MGT training. There is a manual, an MGT manual. All training participants will be sent a manual, and we will go into much more detail about all of the activities at that time.
And Marissa, I just also want to clarify, someone did ask if the book can be purchased without attending the Learning Collaborative, and absolutely yes. So Multidimensional Grief Therapy is available for purchase through any Amazon or any bookstore, I think.
Okay, and so please, if you have questions, feel free to enter them. I'm just going to share a couple of additional resources. So we just wanted to let you know that we at the Trauma and Grief Center do have a virtual learning library where we have a lot of online trainings that are available at no cost, as well as a lot of handouts, including our Power of Parenting series. This was a joint collaboration between the Trauma and Grief Center as well as the NCTSN and those with lived experience that tells parents, explains to caregivers how to discuss different types of deaths with kids. And so that is also available on our website. And then I think, Keith, I'm going to turn this slide over to you to talk about.
Yeah, thank you, Marissa. And we'll discuss this a little bit more, but this is another resource that we have that provides some information around supporting youth, and particularly youth who are in the juvenile justice system or at risk who are experiencing grief. That also includes some information around MGT and what we call our Science and Services Spotlight series. And this is a downloadable document. We'll provide a QR code momentarily about how you as a participant can access the CTRJJ website, including this Science and Services Spotlight resource, which is in PDF format that can be downloaded and shared with colleagues, with persons within your network. It can be posted within your organizations, etc. And it's also written, hopefully, in user-friendly language that if you feel that you're working with a youth or family that could benefit from the information, we also encourage it to be shared directly with youth and families.
I'm seeing a lot of questions about the cost. So thanks to the generous support of the CTRJJ, the MGT training is being sponsored by them. So it's being offered at no cost to participants.
And in case you missed some of those dates, as we work through some other kind of Q&A here, we will make sure to pop up those dates, etc. But it's really important for you to know that in case so you're not madly scrambling this, but please feel free to get your cell phone out and take a snapshot if that would be helpful for you to go ahead and mark this on your calendar now. But everyone who is registered for this webinar will receive an email notification regarding the opening of the application process. And this has been a really overwhelming response and a good way of interest to this webinar. I do want to let everyone know that because it is funded through the CTRJJ grant and collaboration with Marissa and Julie and her team, that there is a limited number of total seats that will be available. And it will be restricted to 50 participants. Pending completion of this first round of an MGT Learning Collaborative, we hope to be able to repeat this Learning Collaborative again in our subsequent funding a year through the CTRJJ as well. So this one may not necessarily be a one-time opportunity. And then Marissa and Julie, can't recall if we had contact information, or would you encourage people to sort of follow and the Lucene Center for other training opportunities aside from the CTRJJ supported Learning Collaborative?
We actually have a link I can pull up if you give me just a minute where people can sign up for our training listserv as well. So I'll pull that up right now.
Excellent. Excellent. Thank you. And there's a few really great questions that have been emerging in the chat as well. I think we've addressed a few of them about the availability of the MGT manual, and Julie, you've already addressed that. I think some questions have emerged around our learning collaborative. And I'm curious, Julie, or Marissa, if you'd like to offer any additional information on potential MGT adaptations for adults. You've mentioned that this has been used with the transition age youth or emerging adults. But any other comments around its use with somebody above age 25, for example?
Yeah. I would say that we have used elements of MGT, even with teachers after the Uvalde school shooting. So there are elements that can absolutely be adapted. It was really designed with children in mind. And so that's why a lot of the exercises and the language is, developmentally sensitive in that way. But a skilled clinician can definitely use elements of this with adults. And what we hear time and time again, even from parents, is, these dimensions of grief totally make sense for me or for my experience. And so we know that it resonates with adults and can potentially be adapted for adults, but we have not studied that population.
And as a follow-up to that, Julie and Marissa, I'm curious, and even my own work, we know, especially when we think about grief and loss, it tends to be experienced in the context of, families, or in the context, whether that's chosen family or blood family. Do you have recommendations, say, for example, as if you're working with a young person within the family, of how the parent or caregiver, similar access points or resource points for them as well?
Yeah, we almost always encourage the caregiver to receive their own treatment at the same time that the child is engaged in MGT. So in a number of the exercises with MGT, they are dyadic, where we will bring in either one or both caregivers, to basically be part of that session. But that is all about the child. That's really not addressing the parent's own grief. So we would always recommend that most often recommend that caregivers receive their own treatment in order to ultimately better support their child, but of course to address their own grief reactions, because oftentimes what happens is as the child progresses through their grief, their loss narrative, that is shared with the caregiver, and that can be distressing to caregivers who aren't prepared for that, or who haven't worked through some of their own grief reactions. So we would just recommend that they receive their own treatment.
And Marissa, you mentioned this because I think, for many of us who are working within the juvenile justice space, in particular, we know that uh, we know of the crossover youth model or the dual status youth model, et cetera. And Have you worked with providing MGT in the context of youth that are dually involved in the child welfare system and the juvenile justice system? And I'm just kind of curious if you have or had any thoughts on utility and or adaptations that may be needed for youth that are simultaneously in the child welfare system and the juvenile justice system.
Yeah, I can touch on that. And Marissa, feel free to jump in. So, we have certainly used this treatment with kids in the child welfare system. So, and this kind of gets back to that question about the ambiguous loss. Because for many of these kids, they may not have necessarily experienced the death of a loved one, but they have been removed from the home, for obvious, reasons. But what gets lost so often is the grief that that child is experiencing. So many times there's this mistaken notion that even if the caregiver was a perpetrator, that the child should feel better being away from that person. And what we see time and time again is that that child is grieving that loss, even if it was an abusive relationship, or neglectful relationship. So, that's one of the things that we really emphasize is providing space for kids in the child welfare system to grieve the loss of their person, even if they're still alive, but have been removed for those reasons. And so many of the exercises within MGT are readily applicable to that population. And so we have certainly used it with that group.
And you mentioned that MGT can be used in individual and also in group. Is when we think about like the upcoming learning collaborative, do you primarily focus the training on, use of MGT as a model in an individual context or a group context, or is it kind of a mix of both? I'm wondering if people might be curious around that.
We try and make it a mix of both. The manual is kind of spelled out more individually, but a lot of the clinicians that are helping to facilitate some of the breakout groups from our end, from the Trauma and Grief Center, have done this in groups. And so they add anecdotally, some of the ways that they've also adapted. And we actually poll our participants early on to find out how many intend to utilize it individually and how many intend to utilize it in groups or a mix of both. And then we try to speak to both of those as we go through the training.
That's excellent. Thank you, Marissa. And I think another question is emerged, and Julie and Marissa, you referred to the phased approach. Are there different training components for those community providers and those non-mental health professionals that would focus on the phase 1 of MGT versus phase 2? And could you talk a little bit about like the implementation or training of both of the phases of MGT and how you support that?
Yeah, so quite honestly, we've had such an overwhelming response from clinicians and mental health professionals who want both days that's what we've focused on for the trainings. So we haven't yet been able to kind of tease out just training people on day 1 or phase 1 and just training people on phase 2. So for our 2-day learning collaboratives, it is the full model. So we will give priority to mental health professionals, not only who are in JJ settings or work with youth who are at risk of becoming involved in the JJ settings, but also mental health professionals who are able to utilize both phases of the intervention.
That's great. Yeah, thank you so much. I will often describe in trauma trainings and other contexts is that it's very difficult for us to think about developing just a mental health workforce to be able to respond to the high need for our youth and really youth and other family members. And that's what I think is a really great element here. Of MGT is the establishment of that phase 1 and 2 as well. But very much to understand the perspective that you've described is that it would be beneficial for mental health clinicians to receive training in both phases.
And that's the caveat there is that not every child's going to need both phases, right? There are going to be a lot of situations or maybe even settings that providers are working in where they don't have the time, or the child doesn't need phase 2. But in terms of the actual training, 2-day training, we will be offering it to people who can attend both full days.
And I think we've hit most of the questions I think that have emerged in the Q&A. Does MGT have any training restrictions? Do you need to be licensed, say, for example, as a licensed professional counselor or a psychologist or a licensed social worker? The question emerged is, can someone like a licensed occupational therapist that has a background in mental health be trained at MGT?
Yeah, there are no specific restrictions in terms of, the application is pretty thorough in terms of asking questions about the population you support and the type of work you do and your ability to implement MGT in your setting. And so we're taking all of that into account. One of the things I also saw is, will the training be available to access later? So if you kind of scroll up in the chat to the link I posted to the TAG Center's training listserv, if you sign up there, you will receive notifications when we offer this through other avenues. And so we offer it in, other times throughout the year. And so that would be the best way to find out about when other MGT trainings are offered.
And Julie, another question came in around the availability of the prolonged grief sort of checklist, or the PGD checklist that you mentioned, is this publicly accessible, or is it um, is it restricted access?
That's a great question. So one of the things that we forgot to mention is that when we do our learning collaboratives, we provide everybody access to our online assessment battery. And that includes the PGD. It includes the very brief PTSD reaction index. It also includes a couple other measures that are publicly available. But technically, a couple of those measures, including the PGD, are not readily accessible by the public. They're actually sold through a company, but we have an agreement with the co-authors of those measures that if this is part of a learning collaborative, they can freely access that measure. So you can either access it through participating in our learning collaborative, or it is available for purchase through Behavioral Health Innovations. That's the name of the company that sells the measure.
And maybe one final question, and then before we move to our wrap up is, and Julian and Marissa, you have both had extensive experience in providing supports to school systems. And of course, we're very aware of the school to prison pipeline, as it affects, youth that are system involved as well. And when we think about that loss as maybe being a peer, a classmate, someone from within the school, can you talk a little bit about any modifications or use of MGT in that context?
Yeah. We actually have used MGT in that context where it's actually been the death of a peer as opposed to a parent or sibling. And utilizing phase one in that context has actually worked really well. I think, what gets a little bit trickier is when we move into phase two and really start to do more of the deep dive around the grief processing. That's when we've had to be a little bit creative about potentially doing some pullouts with individual students. But certainly phase one has been used in that context.
Excellent. Thank you. Thank you so much, Julie. I just want to take a moment and just thank you both very much for this wealth of information. And I can tell just from the chat and the QA, we've had having a lot of interest here. Just as a reminder is, if you registered for today's webinar, you will receive information from the CTRJJ and about this application link for the training as well. And just in wrapping up, I'd also like to just create this opportunity for you to take a moment and scan with your phone this QR code, which will allow you to connect to the Center for Trauma, Recovery, and Juvenile Justice website. And here's where you will find some of the resources that are mentioned in today's training, including that Science and Services Spotlight, which I discussed a little bit earlier. The CTRJJ is also in the midst of releasing a podcast called Roadmap for Change, Trauma, Recovery, and Juvenile Justice. So for those of you who are podcast listeners and working in this space, we encourage you to follow and subscribe to the Roadmap for Change podcast, and particularly listen to episode 4, which features Dr. Kaplow in a discussion around addressing grief as another way for you to tap into information here as well. And finally, before we wrap up, is if you would like to access and download and to keep a certificate of participation in today's webinar, is Riley will be providing a link to this in the chat, so you can click on it live, or you can take a snap photo of this slide, which would contain the URL for you to access the CTRJJ website, where you can download the certificate that's listed here on the slide. In order to access the certificate, you will need to enter the password MGT, and that is case sensitive, so all in capital letters as MGT, for you to download this certificate of participation today. So on behalf of the CTRJJ, Marissa and Julie, thank you so much for the wealth of information today. And thank you everyone for your registration and attendance as well.
Thank you.